मुरली मनोहर गोपाला। मुरली मनोहर गोपाला, मुरली मनोहर गोपाला, मुरली मनोहर गोपाला। गोविंद राधे गोपाला, गोविंद राधे गोपाला, मुरली मनोहर गोपाला। जय मुरली मनोहर गोपाला। जय गिरधारी कुंज बिहारी, जय गिरधारी कुंज बिहारी, जय गिरधारी कुंज बिहारी, श्याम मुरारी गोपाला, श्याम मुरारी गोपाला। जय मुरली मनोहर गोपाला, मुरली मनोहर गोपाला। गोपी वल्लभ दीन दयाला, गोपी वल्लभ दीन दयाला, दीन दयाला, दीन दयाला, दीन दयाला, दीन दयाला। गोपी वल्लभ दीन दयाला, देवकी नंदन गोपाला, देवकी नंदन गोपाला, मुरली मनोहर गोपाला, मुरली मनोहर गोपाला। हरे कृष्णा 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 हरे हरे, हरे रामा 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 हरे हरे। हरे कृष्णा 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 हरे हरे, हरे रामा 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 हरे हरे। हरे कृष्णा 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 हरे हरे, हरे रामा 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 हरे हरे। हरे कृष्णा 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 हरे हरे।
Namaste. Welcome everyone to yet another Yes Talk. Today we have with us Professor Vinaya. Professor Vinaya completed his medical training and post graduation from India before moving to the US for further training. He completed his fellowship in endocrinology, metabolism, nutrition from US and has been in the US for last 25 years. Currently, he is associated with the Division of Endocrinology and serves as an associate professor at the Department of Internal Medicine at Mayo Clinic, Rochester, Minnesota. Today, he'll be talking about body fats with us, and we welcome you, sir, and look forward to your session. Over to you.
Okay. Okay. Can you see my slides now?
Yes.
You want to see the slides?
Well, good evening, everybody. It is indeed a very great pleasure to be here. Thank you very much for the kind invitation and the kind introduction. While I'm really extremely pleased and privileged and very enthusiastic about talking to you, I have a confession to make. When speaking on a yoga, education, and spirituality symposium, I must tell you right off the bat that I myself am not much of an enthusiast or spiritual seeker or a yogi or a highly educated person. I'm just a simple clinician. I deal with extremely mundane things, diseases and other things, drugs, so on. But then really what has still kind of enthused me, or rather encouraged me and still given me the courage to speak, is not my own ability, but the confidence I have in you as a great audience. If you have heard the words in the Ramayana, Valmiki says through Vibhishana, Satsu yo vishwasaha atmanaha na vyatiyate. The confidence one has in good people is greater than the confidence one has in one's own self. So that's actually my credentials. My only big credential is I'm a student of Dr. Bijlani, and this is what I had also learned from him, the words of the Gita again. Vidya Vinaya Sampanne Brahmane Gavihastini Shunichaiva Shvapake Cha Panditaha Samadarshinaha. So the Panditas like you are Samadarshi. You look upon with equanimity on not just a Vidya Vinaya Sampanna, which I'm not, but also all the way down to a Shvapaka, somebody who eats dogs, so an uncultured person. Well, I'm in a country where hot dogs are the favorite dish, but I don't do that either. So I'm somewhere in that spectrum. But then, well, enough about me. So once again, I thank you very much for this opportunity. Let me briefly tell you what I'll be talking to you about. So I have kind of designed my talk to explore a few, like about half a dozen facts and myths that surround this topic of adiposity, body fat and health, how it deals with our everyday living. So let me start with, so we'll actually start with fact and then see what is the myth behind that. So here's one of the first things, which is rather a very broad fact. We all know everybody dies, and in our own ignorance, everybody desires to do so of old age. So nobody wants to die of anything else. But here's the fiction. People just don't die of old age. Everybody dies of a disease. So if you look at anybody's death certificate, yes, it's always nobody is told to have died of old age. So there is something that gets us. So just like death, diseases also is something that we cannot get away from. But that is okay. That's not what we are trying to run away from. We as doctors and we as human beings in general, what we are trying to avoid is getting these diseases at an early age, premature diseases. And of course, the worst thing here is heart disease, heart attacks. We don't want to die of early premature heart attacks. It's so bad to see all these young men in their prime, men, women, who actually get struck down by things like heart attacks and strokes and so on, which are in many ways preventable. And that's what we are going to be talking about. And here's one other big myth. So you will have doctors, and everybody else talk about the sudden heart attack. The fact is there is no such thing as a sudden heart attack. It requires years of preparation. And I'm not saying this with any kind of melancholy or cynicism. What I'm trying to say is this: while cardiovascular disease is the leading cause for morbidity and mortality, and obesity, which is basically excess fat tissue, that is excess adiposity, increases the risk for cardiovascular disease, it also is a slowly evolving process. And therefore, because of this long incubation period, it affords us an excellent opportunity for prevention. And so this is what should keep physicians up at night. Or what am I doing for my patients to prevent this? And this is what should enthuse all of us to be doing something to prevent it. So there's no such thing as a sudden heart attack. These things happen, and happen right under our nose for a long time. Excuse the pun. Yes, something's happening right under the nose here. So that's what we are going to be talking about. Now, here's something else. So yes, so it's a given, it's a fact that obesity or excess adiposity will lead to adverse heart outcomes. People who are obese clearly are at high risk. But then it's a myth that all obese individuals are unhealthy and at high risk. So one doesn't necessarily have to be doomed to ill health just because by being fat. And the reason why I say that is, so there was this beautiful study that was done way back, but was published almost like 2-3 decades ago. So this was by Stephen Blair and others at the Cooper Institute in Dallas. So this is a fantastic place. So at the Cooper Institute, everybody who goes there gets an executive physical where they get an exercise stress test. And then they have been followed for almost 10-15 years. And what they noticed was that the risk of dying from cardiovascular disease did not just depend upon your body composition, but it depended more on your fitness. So if you just concentrate on just the left part of this graph, so as you can see here, so this is the data on the fit people is the blue, and the unfit people is the red. So by looking at the performance on the treadmill stress test, so you can classify people as being fit or unfit. And so here are people who are normal weight, who have a normal BMI. Of course, this is what everybody wants to be, not fat and fit. So compared to them, people who are fat, obese, but who are fit are just a slightly higher risk, 1.6, and it almost touches this line. But whereas compare this to somebody who is not fat, but yet not fit, their risk is even higher than somebody who is overweight, but is fit. Of course, if you're both fat and unfit, then of course the risk is 5 times that of the reference. So the point that they made in this study is that it is not about being fat, it's about being fit that counts. So that led to this so-called fat but fit paradox. So diseases do not necessarily depend upon the body fat. And here, the body fat was measured by way of a BMI. Now, some people said, oh, the BMI is a poor measure of adiposity. So then they looked at actual body fat percentages. So these were people with a low body fat and a high body fat. And here they looked at truncal obesity, which we think is probably the biggest determinant of overall insulin sensitivity and cardiovascular risk. And again, it's the same thing. So you will see that people who are fit are fine, no matter what is their body fat, how obese they are, how much BMI they have. So this led to this thing, this feeling that being fit is probably far more important than being fat. And there are other studies also which have supported it. And much of this decreased mortality was related to cardiovascular diseases and also cancer. So these are the 2 big killers in the developed world, and unfortunately now even in the developing world. Now, however, I must tell you that it's not that universally this has been shown more recently. So this was, I think, a Spanish study that also followed a large number of people, I think about 3,000 individuals. And so what you can see here is that this calls into question this fat but fit hypothesis. What you'll see here is this is the risk in people who are normal weight. And so to the left extreme are those who are active, and then these are insufficiently active, and these are inactive. Yes. And this would be in people who are overweight, and then the next panel is in those who are obese. So what we can see even here is that there seems to be a linear relationship. So no matter what your body weight, if you are more fit, yes, or rather if you're less fit, you can see that the risk increases. So being more fit is good. But then even being fit, like this group, will not rescue you from all the adverse effects. And here they looked at risk specifically in people with comorbidities like diabetes, hypertension, and cardiovascular, and hypercholesterolemia. And what you can see is the greens, especially those with diabetes. So if you have diabetes and obesity, even though you are active, your risk is so much higher than somebody who is not obese. So they called to question about this. Maybe we've gone a little overboard with the fat but fit hypothesis. But I don't think we should actually go into an individual study. So there are a lot of, if we go into the nuts and bolts of the study, so there is some controversy about the way fitness was measured. So here, while in the Cooper Clinic studies, so they were actually measured objectively with an exercise stress test. Here it was the patient reported, or rather the individual reported physical activity. So lots of people have some reservations about the study. But I think for us, it suffices to know that being fit will certainly reduce. Even here, you can see this. So being fit will reduce, but perhaps it does not eliminate all the health risks due to obesity. So it might be prudent to target both fitness and fatness. So, and in many ways, it's not like whatever we do to remain fit will also help us get rid of some of the extra fat. So I don't think that this is more of an academic discussion. To be healthy, I think will help with both these aspects. The next point I want to make is this. Let's get to something closer to home, and that's about Asian Indians. So we all know Asian Indians, and by we, I mean everybody, of course. You know, we've seen this amongst our friends, amongst our relatives, how Asian Indians are at very high risk for cardiovascular disease. Unfortunately, the whole world does too. So there is a lot of studies even done outside India looking at why Asian Indians have this very high risk for cardiovascular disease. Many times, India is considered the diabetes capital of the world. So it is true that people, Asian Indians who are obese and have high cholesterol, are at high risk for cardiovascular disease. But here is a very alarming fact, and that is that traditional measures of obesity and lipids do not accurately identify Asian Indians for their high cardiovascular risk. What I mean is this. This was a beautiful study that came out very recently, just a couple of months ago in the Journal of Clinical Lipidology. So there is this very nice registry. I think it's based off 2 hospitals in New Delhi itself. It's called the North India ST Elevation Myocardial Registry, Myocardial Infarction Registry. So this is the worst myocardial heart attack you can have, the so-called ST elevation. So they looked at all of those people who came with this very bad heart attack. And then they looked at all the risk factors that they had. And then what this paper reports is the statin eligibility. But really it means who are the people who are at very high risk. That is to say, if I had seen them the day before their heart attack, would I have recognized them as being at high risk and therefore given them a statin? That's the drug that we commonly give to prevent a heart attack. And here's the shocking truth. So there are different ways of assessing this risk. So all the good institutions have come out with their own guidelines, and there is a lot of controversy about which is the best. We will not get into that, but these are the ones. This is the American College of Cardiology, this is the USPSTF and the NCEP. So it doesn't matter. No matter which tool you had used, you would have only recognized barely 50% as being at high risk. And of course, all of these are people who have proven to be at high risk because they already had a heart attack. So only 50% of the people that we would have seen the day before their heart attack, we would have accurately identified them as people who would likely get a heart attack. So number one, we are already not addressing people who we know are at high risk, and we are also missing with our traditional assessment people who might be at greater risk. So this is something to be kept in mind. And we've tried to understand why this happens. Maybe it's not because Asian Indians just have high cholesterol. I don't think you can make out all the details, but then I just put this up just for you to show. So this was a beautiful study where they compared Asian Indians with whites and blacks. And the point was that traditional things like a high cholesterol is not really found. So Asian Indians don't have high cholesterol, either the total cholesterol or the bad cholesterol. What they have is higher levels of something called triglycerides, which is the fat in the blood. And more importantly, they looked at something called lipoprotein profile. So, what happens is cholesterol is not something that's freely floating in the blood. So the cholesterol is carried in these particles called lipoproteins. And there is a lot of nuance to the way the lipoproteins are. There's numbers and their sizes and so on. So that's what matters. And we have recognized that there are some patterns which are very heterogenic, which are bad. And Asian Indians, unfortunately, have an increased prevalence of these very toxic lipoprotein particle profile. We know that this happens in most people who are obese. But here's the thing, as you can probably make out in this slide, Asian Indians, this is the black bar. So they have a higher prevalence of these abnormal lipoproteins even when they are not obese. So these are people whose BMI is 21, and these are people with normal BMI. These are people with a high BMI. Of course, when you have a high BMI, you're expected to have these abnormal lipoproteins, like how even the blacks and whites do. But then even with a seemingly normal BMI, we seem to have a lot of these abnormally sized and abnormal composition of these lipoproteins. So all of this probably predisposes us to cardiovascular disease. Now, why am I saying all of this to you? Okay, of course, I know there are some of you who are probably very enthusiastic researchers. So these are the things that I want to inspire you to work on. But there's also a reason why all of us should know about it. Keep this in the back of our mind, and then we will come back to this. While we examine one other very important fact about adiposity. Yes, it is true that excess adiposity is detrimental to overall health, and it is strongly associated with both diabetes and dyslipidemia. That's high triglycerides and so on. So that's well known. But then can we extrapolate this to say that the main culprit here is adipose tissue? It's just a bad thing. Having fat is bad. And this is what is responsible for causing all the diabetes and dyslipidemia. This is one of the big myths that I want to dispel. And I learned this lesson through this very, very interesting patient. So this is one of the first patients I saw when I came to Dallas as a fellow in endocrinology. So as you can see, this person should be the picture of health. Okay, so she looks wonderful. So there's no fat. She's lean and beautiful and everything. So she's a 31-year-old African-American lady I saw, has the perfect BMI. And then we measured her body fat and it's 8%. Oh, that's wonderful. People would kill to have something like that. It's so good. But here's the problem. She was one of the sickest people we saw. So she had diabetes and high triglycerides from a young age. And those of you who take insulin probably know. So you would take like about 10 units, 15 units, 20 units. If you take 50 units, you're already, oh my God, what's happening? This person was taking 700 units of insulin a day, and she was on some very strong medicines for cholesterol. And despite all of that, so her A1C, so people who are familiar with this, you know, you want your A1C to be 6, 7, something like that. Hers was 9.5. So clearly she wasn't doing well. And the reason for all of these things is because she has a condition called congenital generalized lipodystrophy, like she was born without any fat. So having no fat is not good at all. In fact, these are the people who have the worst insulin resistance, the worst complications of what we commonly associate with having too much fat or with obesity. We know people who are obese have diabetes and high triglycerides and so on, but people without any fat, it's even worse. And the reason why I'm mentioning all this is, of course, you'll probably never see one like this. And this is, I know this is a very unique audience, but then this is like, I don't think there's anybody amongst you, hopefully. So this is like 1 in 10 million. So it's a very rare condition. But the reason why I still bring it up is, as William Harvey says, nature sometimes, you know, it reveals its secrets more openly in those cases where she shows traces of her workings apart from the beaten path. So sometimes examining these very rare patients tells us what is happening on in the more common aspects. And what I mean is this. So this has taught us all we really need to know about the real role of fat, of adipocytes in lipid homeostasis. So we think this is what normally happens. So this is our intestines, the gut we eat, and all the fat that we eat most of it is actually stored in this adipose tissue or in the fat tissue. And that's an extremely good thing, because then the fat goes where it is supposed to go, as opposed to going to other tissues, such as this is the liver and this is the muscle. Now, they have things to do on their own. So the liver is the chemical factory. So it has to do all of these other important activities, the metabolic activities. And the muscle, of course, will, you know, it's primarily meant for energy. and for moving and all of these things. So they get just a little bit of the fat. Most of it is where it is supposed to be. And the little bit of fat that they have, they use it for whatever is required, mostly for energy generation. But what happens in people with lipodystrophy is this. So if you don't have this adipose tissue, then all of these dietary fat is getting diverted to the non-adipose tissue, that is to the liver and the muscle. So it's not their role to be storing all this fat. And it's this extra storage of fat which is what causes their dysfunction, which is what leads to so-called insulin resistance, the high triglycerides, the diabetes, and so on. This is something clear to understand in people with generalized lipodystrophy, but something very similar happens in obesity as well. So in obesity, what happens is we all have a finite capacity to carry fat. And once we have done that, then all the extra fat that we are putting away, we have no place to put. The adipose tissue says, okay, I'm done. I can't store anymore. That's when we begin to spill this into the other tissues. And that is what causes all the metabolic complications of obesity. The same thing gets magnified, of course, if you have no fat at all, like in lipodystrophy, but it's very much the same pathophysiology that's happening in people who don't have lipodystrophy, but who have obesity, who have kind of become qualitatively lipodystrophic in that they do not have any more fat tissue to store. Again, the reason why I'm telling you all this is, one, because I want you to love your fat, not all of it, but at least most of it. It serves an important function. So it's not having adipose tissue which is causing the problem. It's actually in some ways not having adequate amounts of adipose tissue. And you might have seen this. There are some people who can become extremely obese but never develop diabetes or other thing because they're blessed, so to say. I'm sure they feel miserable about it, having too much fat. But then having fat in the right place is fine. But then it's when they cannot store fat anymore in their adipose tissue and it starts leaking, so to say, into this ectopic tissue, that's when we get all the metabolic complications. And generalized lipodystrophy is this rare disorder which has served as an excellent model to understand the role of adipocytes. And the metabolic complications are likely due to the small amounts of ectopic fat which accumulates in the non-adipose tissue. Again, why am I telling you all this? I'm telling you all this because I want you to realize that, therefore, even modest weight loss is beneficial. So you should not be aiming for, oh, I will never be able to lose these 50 kilograms. I'm overweight by 50 kilograms. And unless I do that, so what's the point? Well, let me just, it's a futile exercise. No, it's not a futile exercise because you don't have to lose all of that. Of course, it's good to lose all that weight and get to be normal weight. But even before that, and it's actually kind of like last in, first out. So this is the fat that went into the muscle and in the liver where it's not supposed to go. And usually that is the first fat that we lose once we get into healthy lifestyles. So even modest weight loss is beneficial. Again, what does the Gita say? Swalpamapyasya dharmasya trayato mahato bhayat. So if that is true of the highest dharma, it's actually true of some of these mundane activities also. A little bit of diet, a little bit of exercise will still, trayate mahato bhayat, will protect us from great fear. So we should keep that in mind. And I'm not making this up. So lots of trials have shown this. So one of the most celebrated trials is this diabetes prevention program. So this was a big NIH study that had about 3,000 people who were all at high risk for diabetes. So they didn't have diabetes, but they were at high risk for various causes. They had some mild impaired fasting glucose, they had gestational diabetes and so on. They wanted to see whether lifestyle intervention or a drug therapy, pharmacological therapy. They used a drug called metformin, which we believe is the first best medicine for diabetes. So they wanted to compare that with lifestyle on the prevention of diabetes. So it was an intense individualized intervention. The goals of this intervention was, as you can see, they were fairly modest. So it was 150 minutes per week of moderate intensity physical activity. That's about 30 minutes, 5 days a week. And all of us are busy, but surely we can find 30 minutes most days of the week. So if we can do that, and the targeted weight loss was also about 7%. So it's not about losing 50 kgs, 20 kgs, and so on. So they lost about 10 to 15 pounds. So that's barely 5 to 10 kilos. So even with this modest changes, see what happened. So this is the diabetes prevention. So this is the diabetes prevention in this lifestyle group versus the comparative group. And it was 60%. Whereas the best, greatest drug that we have for diabetes only prevented at 30%. So compared to the drug, lifestyle was twice as effective. So even modest changes are extremely beneficial in terms of reducing the risk of metabolic complications. There was one other interesting, now everybody talks about the diabetes prevention project in terms of what it did for diabetes prevention. But then there's a follow-up study of this where Goldberg and others, they looked at these advanced lipoprotein particle profiling. So remember what I told about Asian Indians having this abnormal lipoprotein profile. Like they don't necessarily have high cholesterol, but then they have these high triglycerides, they have lipoproteins which are very small and dense. So these people in this study, they looked at, they dug into the freezers and looked at changes in these lipoprotein particle profile. Again, I won't bore you with the details, but then what it showed was this. So the particle numbers, the number of these very toxic particles, very atherogenic particles, the VLDL and the LDL, the particle concentration decreased most in the lifestyle group compared to the drug group. And the particle size increased in this group. So basically what we want is we want big fluffy LDL particles rather than small dense particles. So if we have all our cholesterol contained in just a few big particles, it's much better than having it spread across number of small dense particles, which are more likely to go into the vessel wall and cause plaques and so on. So essentially we can get very favorable changes with all these complex abnormalities that happen with these lifestyle changes. And therefore, this is what all the guidelines say. And I've just picked up one of these guidelines. So this is probably the in some ways, the latest and greatest guidelines. So it is authored by, rather chaired by Scott Grundy. And those of you who are in this field know what a doyen he is. And I've had the extreme good fortune of working with him, of learning with him. So this is the NCEP guidelines, which is now the AHA guidelines. So the main thing is this. So they found that, it's like a huge document. It's about a 70-page document, but then they distilled it all into 10 take-home messages. And the very first thing they want to say right off the bat is this. In all individuals, emphasize a heart-healthy lifestyle across the life course. And what is this heart-healthy lifestyle? It's not anything new. It's things that we know, but I think it's good to actually hear it from the horse's mouth, so to say. So these are probably the people who have all their life, all they've done is just look at cardiovascular risk and so on, and have done this very dispassionately. And this is what they say. The first thing everybody should do is this. Emphasize intake of vegetables, fruits, whole grains, legumes. And I've just copied exactly. I've not made anything up. Not put words into their mouth. Legumes, healthy protein sources like low-fat dairy products, low-fat poultry without skin, fish, seafood, and nuts, and non-tropical vegetable oils. So this is exactly what our grandmother told us, and there was probably a reason to, well, not all of it, but anyway. So they also said, limit the intake of sweets, sugar-sweetened beverages, and red meat. Now, sugar-sweetened beverages is really and what they are really referring to is this high fructose corn syrup. In the US, of course, it's very rampantly used, like, things like all the soda pops. So they are laced with this high fructose corn syrup, which is real metabolic poison. So it seems to do a lot of bad things. Primarily, there are these what are called transcription factors in the liver, which are activated by this high fructose corn syrup. And this kind of stimulates the liver to make a lot of fat, and it's just bad. We should avoid that to the largest extent possible. We should focus on optimal weight, other comorbidities, and we should do this with cultural and personal preference. It's not that everybody can do a Mediterranean diet or something. So it should be culturally appropriate, whatever we recommend to patients and whatever we adopt. So, and I'll get back to this a little while later. Aerobic activity. So that's very, very critical. So what is recommended is something like at least 3 to 4 sessions per week of 40 minutes of moderate to vigorous intense physical activity. What I tell my patients is this. You just need to eat on the day, you just need to exercise on the days that you eat. So at least that should be our goal, is to exercise on most days because that's just how the body is built. And it's probably better to split it. There was a beautiful study where they compared people who had done 45 minutes of exercise in the morning versus those who did 15 minutes 3 times a day. So those who split their exercise, they had much better metabolic profile. Again here, swalpamapyasya dharmasya trayate mahato bhayat. Doing even a little bit is good, but doing more is actually better here, especially in terms of cardiorespiratory fitness. It's been shown that the intensity of exercise is important. So people now talk about something called high intensity interval training. Like if you're running, you run for a minute and then you walk for about the next 2 minutes to catch your breath. Then you run for that another minute. So if you're able to do that, that's shown to be extremely beneficial. It improves your good cholesterol, it improves your cardiovascular fitness. So yes, the more you do, the better. But we must do something. We must get moving. So being sedentary is now the new smoking equivalent, as you probably heard. I think it's catching up even with the lay media that sitting is the new smoking. So that's the bad thing. We'll talk a little bit more about the diet. It is true. So that judicious manipulation of macronutrient content in the diet can aid weight loss. So by macronutrient content, you mean, you've heard of this. People talk about high carb diets, low carb diets, high fat diet, no fat diet, paleo diet, and keto diet, and whatnot. So yes, so they're all actually pretty good. But here's this thing. It is a complete futile exercise to be looking for that perfect, most effective dietary intervention program. So there is no such thing. There is no such thing as this is the best diet. Okay, so it's just a scam to think that, oh, this is the best diet. Once I'm on this diet, everything will be fine. Again, I'm not making this up. So this is one of the to my mind, it's actually one of the best papers I have read on looking at the effectiveness of dietary intervention. So what they did was, they followed about 24 people in each group. So they looked at people who had followed these different diets. So the Atkins diet, the Atkins diet is the so-called keto diet, then the zone diet, which is again something similar. They focus on some good carbs and so on. The Weight Watchers diet, the Dean Ornish diet, which is a low-fat diet. All of these things. And then they looked at the weight change by the different diet type. And so this is the individual weight loss. So yes, so majority of them do lose weight, anywhere between 5 to 20 kilograms. So that is very, very reasonable. That's about what most people lose. Some people, of course, don't, as in any other study. So all of them are probably effective to different extents in different people. But then they tried to look at what is it that determines the weight loss? And this is what they found. It was actually how adherent they were to the diet. So they got some measures of some scores of adherence. And when you looked at the weight loss as a function of these mean dietary adherence, you will see that obviously those who had more adherence had greater weight loss. And it had nothing to do with which diet group that they were in. So you can see those who actually lost more, all it mattered was that they were more adherent. So there are some triangles here, there are diamonds, there are squares, so there are all kinds of people, and they are spread all over here. So what really matters is not which diet you are, it really matters how adherent you are. And of course, there are some people who find it nicer to be on an Atkins diet compared to an Ornish diet, and there are others who like to be on a low-fat diet. So it's about finding what best suits your preferences. So that's where we get back to the guidelines about cultural and personal preferences. So we should not be very prescriptive about lifestyle changes. So each person should be able to find out what works best for him. So because this is not a 100-meter dash, so this is like a marathon. So you must be able to adhere in the long term. So you must be able to find out what you can stick to and do so. This is a paper that just came out yesterday. So you can see April 21st. So there is all this, and in the New England Journal of Medicine. So there is all this interest about this so-called intermittent fasting or time-restricted eating. So many of you may actually be doing this. So where, you try to not eat for a long period of time. You skip breakfast or you skip dinner or something so that, and then people thought that this is very great. So you're going to burn more fat, you make more ketones and whatnot. So this was a big Chinese study which compared the effectiveness of this intermittent fasting with regular caloric restriction. And as you can see, the two curves, there is absolutely no difference. So even something that is extremely in vogue now and has evoked a lot of interest, well, it still works. I'm not saying that it doesn't. So you can see that, yes, so intermittent fasting is effective, but by no means is it any more effective than regular caloric restriction. So anything that you can do to decrease your caloric intake and increase your energy expenditure will be beneficial. And if intermittent fasting will facilitate you being compliant with such a lifestyle, then yes, certainly, absolutely, you should do that. The other thing that we should talk about is this. What about fat in the diet? We spoke about fat in the body. What about fat in the diet? While it is certainly true that high-fat diets have contributed to this epidemic of obesity and cardiovascular disease, it is not true that we should eliminate all fat. It's not that, high-fat foods and foods which are rich in cholesterol are necessarily bad. In fact, if you actually look at the guidelines for people who have high triglycerides, these are the people who have the worst metabolic complications. Of course, caloric restriction is important. So that's the main thing. So if you eat a high-fat diet, you're getting a lot of calories, which can promote obesity. So you should restrict it for that reason. But then amongst eucaloric diets, like if you're going to do a 1600 kilocalorie diet, it might actually be better in terms of the macronutrient composition to have a moderate to high-fat diet rather than a high-carbohydrate diet. This is what multiple studies have shown. And unfortunately, as is our practice, so we always take everything to an extreme, and then so people say, oh, all carbs are bad, oh, rice eaters are doomed, and so on. So that's not true either, okay? We don't have to be on a no-carb diet, on a keto diet or anything. Dietary carbohydrates, it might be a good idea to probably not to exceed 50 to 60% of the total calories. Like most of those studies where they have shown that high-carb diets are bad, so this is where people would eat like 70, 80% of their calories were coming from just carbohydrate sources. So that's probably not a good idea. So we need to have a balanced diet. And with carbs, of course, there's a lot of misconception. And, I've learned a lot over the years. But then what I learned the best was what Dr. Bijlani had taught me once before. And he would say, a carb is known by the company it keeps. So it is not just about the carbs that you eat, it is how you eat it. So as long as you eat carbs with a lot of fiber and with other proteins and fats, then the glycemic index and other things are not so bad. And it's probably still a good energy source. So we should mainly try to get complex carbohydrates as part of a mixed meal. We should try to get 20 to 30 grams of dietary fiber. But what we should avoid are the simple sugars and fructose. So these probably should be in extreme moderation. And when it comes to fat, saturated fats, so these are primarily fats of animal origin, red meat, and then, things like whole fat dairy products. These should be restricted, probably less than 7% of the total calories. Whereas monounsaturated fats, which are primarily rich in things like certain oils, canola oil also, not just olive oil, nuts. So nuts are extremely good, and it doesn't have to be very expensive nuts like almonds and so on. Even groundnuts is probably is very good. So nuts are good sources of monounsaturated fats. And for those who eat fish, really, that's extremely good. Marine long-chain N3 fatty acids have been shown to be very, very beneficial. The question always comes up, is there an ideal, which is the cooking oil, that cooking medium that we should all be using? Again, this unfortunately, I don't think there is one perfect oil. There is so much nuance to this. So the amount of the N6 to N3 ratio, while we do believe that polyunsaturated fatty acids are good, so, having too much N6 is probably, anyway, what is N6? Well, we didn't really talk about all of these things, but I don't think this is the right forum to be doing all of these things. But maybe we'll just simplify this and say, it is good to probably have a mixture. So, you know, if you can, of course, eat only olive oil or something, that's great. But otherwise, the traditional Indian mixture of, you know, having a little bit of groundnut oil plus canola oil plus probably things like sesame oil. So all of these things are good. And the ICMR and the National Institute of Nutrition, they have done human service here. So they have, if you look at this publication, so they have very good guidelines on the kinds of oils to use and so on. But again, I don't think that there is a perfect oil or something. So it has to be moderation and a mixture. About eggs. So just a few small points about eggs. So what about now when you speak about high cholesterol foods? So egg is, of course, it's just loaded with cholesterol. So is it a good thing or a bad thing? The long and short is it probably is not a bad thing. So this is like multiple studies which have looked at whether high egg consumption increases the risk for cardiovascular disease. And as you can see, so this is the final thing. So it shows that the risk is not particularly different between those who eat more eggs and less eggs. So probably it is not really as bad as we had long imagined. And in fact, there are some fascinating, this is a case report in the New England Journal of Medicine many years ago about this man who had a psychiatric disorder and would eat 25 eggs a day. So all he ate was a soft boiled egg every half an hour or so. So he would just eat eggs and he thought that's going to kill him, but it didn't. So they studied him in the University of Colorado and you can see his cholesterol was great. And then they studied what are all the changes in the body, how the body responds to a high cholesterol diet. It doesn't necessarily increase your cholesterol. So for most people, it's not a big deal, but then still some caution is probably necessary. So in some subgroups of people, like in people with diabetes, yes, excessive egg consumption does indeed increase the risk for certain cardiovascular outcomes. So moderation is important, but I think the previous concern we had about, you know, so the guidelines were you should have less than 200 grams or 300 grams of cholesterol in the diet, which is about the amount of cholesterol in one egg. So the more recent guidelines do not mention that. In fact, the official position is that cholesterol itself is not a nutrient of concern for overconsumption. What's more important is this: diet is important, and I'll actually end by you know, recounting a patient experience. So again, I won't bore you with all the details. So, but here's somebody who has a very complex dyslipoproteinemia. So this is like the typical Mayo Clinic thing. Okay, so he comes for something, but then he's got, you know, his cholesterol was so high, you can see that it's kind of exuded. So these are what we call tuberous xanthomas. He had palmar xanthomas. So we did some fancy testing and genotyping and so on. So he has this very rare condition called familial dysbeta lipoproteinemia. So how did we treat this? Very simple. So all we did was to tell him to watch his diet, avoid simple carbs, decrease saturated fats, lose some weight, and so on. So, and you can see that he did remarkably well. All he had to do was to lose this weight, and then you can see that his triglycerides actually came down by more than 50%, 400 to 188. This is something I show all my fellows, so that's why this is it's more like, it's very technical, this slide, but then I think you get the point. So even in people with very complex monogenic dyslipidemias, dietary intervention is extremely useful. And this is not just anecdotal. So they did this beautiful study in the Cleveland Clinic. So they had patients who had severe refractory hypertriglyceridemia. So these were people whose triglycerides were over 500. They were already on medications. Many of them had already been seen in the lipid clinic and so on. But then just to see what happens. So they sent them all to a dietitian again. And again, the advice was not anything novel. So this is what we all know: decrease your simple carbs, decrease saturated fat. And you can see that within 6 weeks, so post this medical nutrition therapy, there was a 50% reduction, even in people who are already on medication. So it's very, very important to never forget the fact that diet is probably the most important factor when it comes to treatment of obesity, dyslipidemia, diabetes, all of these metabolic disorders. While it is true, it is also important to know this, okay? Healthy therapeutic lifestyles certainly decrease cardiovascular risk. But then we should also not go too far to the extreme and think that drug therapy is useless. Okay. So many people have this thing. So you'll have, like, the internet is replete with all of these people who say, oh, metformin kills you, statins kill you, all drugs are bad. And I don't think that is true also. So they have their place, and we should recognize that. And we should recognize that simply because there is no way we can completely ignore facts. So these are the facts. So this is just looking at statin therapy. So I've just taken one of those. This is probably the best drug we still have in terms of reducing cardiovascular mortality and morbidity. So across a wide group of studies, across different statins. So what you can see is there's almost a linear relationship between the ability of this drug to lower cholesterol and therefore lower the risk. So whenever you lower your cholesterol by using a statin, you lower your risk. And all of this was done in people who already had optimized their lifestyles. So I think it is important to give credit where it is due. So the drugs do have a role to play. And yes, I'm not saying that they're great. I mean, that they're not, that they're not being misused. Are statins overprescribed? Yes, perhaps, yes. So, so the lay press has had a field day making fun of how we overprescribe statins. So this is actually a cartoon that came out in the New York Times when the new statin treatment guidelines were issued. So they said the new guidelines for statins. Step 1, check your pulse. If you have one, you should be taking statin drugs. So unfortunately, we've almost gotten there, but I don't think that we're really that bad. But yes, in the sense, many people do benefit from statin therapy. We should avoid overprescribing, yes. Do they completely eliminate risk? That's the other thing. No, they don't. So this is like, it's not a Ramaban or anything. So if you look at the actual risk reduction, so yeah, even at the best of the trials, it's just about 30-40%. That's all is the risk reduction. So there is still an enormous amount of residual risk. So we are not eliminating cardiovascular risk. So when people say, oh, I've taken this drug, but still I had a heart attack. Yes, it does happen. Nothing will completely eliminate the risk, but then it substantially reduces the risk. Do they have side effects? Yes, absolutely. So statins do have side effects, just like any drug. It mainly causes some muscle pain. High doses statins do probably increase the risk for diabetes. Yeah, I've had many, no, they are experts. So many real experts also, I don't want to take names, they've given lots of symposia on how the epidemic of diabetes in India is because of people using a lot of cholesterol medications. It is true, statins do increase the risk for new onset diabetes, but what they don't tell you is this. So people have actually worked out the numbers. So you have to treat 550 people with statin to get one new case of diabetes. And that is true, you'll get that one new case of diabetes. But when you treat this 550 people with a statin, you avoid 6 heart attacks. So that's the cost and that's the benefit. So we should always keep that in mind. So when we decide to do or not do drugs. So they have side effects, but it's really not as bad as as some people make it out to be. Okay, so it's funny. Okay, in terms of lampooning doctors and others, the pharmacy companies, but they still have a role to play. So we should realize that. So they are quite useful. So in conclusion, yes, healthy lifestyle habits, these are the cornerstones for disease prevention and treatment. We should avoid obesity, we should avoid overnutrition, regular physical exercise, stop smoking, alcohol misuse, address stress. Now that's the most important thing. But again, as I told you, I have very little expertise on mental health and other things, on mental well-being, but then you have so many other great speakers who have spoken on this. So I haven't spoken much on the stress. But then don't think that all medications are bad. So they have their place. As a second step, in many people, addition of medications, which have been proven to be safe and effective, is a useful second step. Finally, I just want to remind you of this beautiful lines from Sir Edwin Arnold's Light of Asia. So if you remember, this is the book on the Buddha. And then, so The story goes something like this. This was when Buddha was still a seeker, and then he was given to extreme asceticism. So he had completely given up all food, and he was just skin and bones and almost dying. And then he hears these group of dancing girls who actually go around singing this song. And the song goes something like this. Fair goes the dancing when the sitar is tuned. Tune us the sitar, neither low nor high, and we will dance away the hearts of men. And these are the most famous lines. You've probably heard this many times over. The string overstretched breaks and the music flies. The string over slack is dumb and the music dies. Tune us the sitar, neither low nor high. And the Buddha, I believe, so this was his moment of enlightenment too. So he then decides to go on the so-called middle path. And that's when he attains liberation or nirvana or whatever. Okay, so but that's the point. So we need to be on the middle path. So we need to avoid excesses of everything. And that's probably the way in life. And that's the way to a healthy life as well. I'm sorry. So thank you very much. Again, as I told you, it's a very great privilege. And thank you for the patient listening. If you have any questions, I'll be more than happy to take them.
But it will take a while for the audience to recover from this extremely mesmerizing talk. Friends, you might have seen that when Vinay said that he's a simple clinician, that was true to his name. You know, his name is Vinay, which itself means humility. So true to his name, he is extremely humble. A person who is at home equally with the latest in scientific medicine and with Sri Aurobindo's Savitri on one hand and the Gita and Sir Edwin Arnold's Light of Asia, can't be just a simple clinician. And as expected from a man with this type of wide reading and scholarship, he ended on a note of moderation, and there again he brought in those beautiful lines from Sir Edwin Arnold. By now there might be some questions in the chat, and maybe some of you may like to raise your hand and ask a question. So please go ahead.
Yes, I can see some questions here. Does menopause cause weight gain? Yeah, actually it's true. Well, in the sense, do postmenopausal women have higher risk for weight gain? That's actually true. We don't completely understand whether that is related to the hormonal changes or what else happens. Yes, but then to answer your question, yes. So probably the best study that looked at us was the Women's Health Initiative. So this followed nurses over their lifespan, and what they actually found was, yes, so there was weight gain, but then the people who did not gain weight exercise for about 45 minutes a day. So it's not inevitable, but it is much harder. So you need to exercise for nearly 45 minutes a day just to avoid weight gain. So yes, I mean, so as we age, lots of things change. And one of them is, yes, so it has to do with fat. We have less lean mass, our metabolic rate drops. So there is a higher risk for weight gain, yes. So hormonal changes do probably influence that as well. But it is not inevitable. But it is, yes, I completely agree with you. Then Amrita has a question. Could you throw some more light on sugar intake? How much is the right amount? So if you're talking about refined sugars, so probably, I don't know, lesser the better. So it is, we really don't need refined sugars at all. Yeah, but then again, we don't need to be so hung up on it. I've seen people who get mortified at having taken any sugar at all. So yes, I think less. So there are numbers. Yeah, we should probably have less than 5%. So is but you're not going to actually count those things. So that's more for people who are going to design a nutrition study. That's what it is. But yes, clearly having a dessert every day is not a good idea. And but then yes. But again, we should not equate sugars with carbs. So the complex carbohydrates, and that includes even rice. So it's not that we should completely give up rice, but as long as we eat rice with legumes, with vegetables, that's okay. But yes, perhaps restricting sugars to the extent possible is very good. Simple sugars. Yes, it does. I've gained 6 pounds despite Zumba. Yeah, I know. I completely sympathize with you. Yes, it is. But again, I don't think you need to be too worried about it. You're doing Zumba 5 days a week, and that will keep you healthy. So that's the end game. So the end game is, remember the first slide I showed you is to avoid those sudden heart attacks. So you're doing that. Okay. So remember that you're not trying to just lose weight. What you're trying to do is to be healthy. And every little bit that you do will help you in that. And so that's how we should measure. I tell my patients, all I'm doing is to try to keep your life boring. Okay, so like nothing happening is very good for a doctor. Like if you have to rush to an emergency room and so on, then that's not good. If you spend all your time not worrying about these things, then that's the best thing. So good. If you are still able to do Zumba, good. That means you're in good health, and that's all that matters. Is intake of ghee good for joints? I actually don't know. I don't know if anybody has actually looked at this thing. Perhaps they haven't. I don't know. Now, ghee in general, we want to think that too much of saturated fat is not good. But that's not to say that eating all ghee is bad. So people have done glucose excursions, eating rice alone or rice with ghee. And actually, ghee has been shown to reduce the glycemic load and glycemic index. So again, I'm not going to say anything is bad. Okay. So yes, of course, if you eat a lot of ghee, which is very concentrated calories, and then you're going to gain weight. So that's not good. But then if you eat the same amount of calories, like if you're going to eat less rice with ghee, then that's good. Then you're actually having a mixed meal. You will have lesser glycemic load. And so that's, is it good for joints? I don't know that. I don't know that. Meenakshi says there are divergent views on statins. It is seen to affect the kidneys. No, that's not true. So statins have never been shown to be hard on the kidneys. In fact, there are studies in people with end-stage renal disease. And there is controversy that those people did not actually have the same benefit. So people with advanced kidney disease may not have the same benefit, but they did not have higher side effects. So I don't think that there's any data to show. Yes, of course, they have side effects. So they can cause muscle pain. And yes, so people who have advanced kidney disease may be at higher risk from certain statins which are excreted through the kidney. So you should be very cautious about it. And a person who gives you must be aware of which statin to use and in which dose and so on. But a blanket statement that statins are bad on the kidneys is probably not right. Do statins help? Yes, they do help. They do help, but in the right context, under the right circumstances.
It seems there is no other question, but I thought I'll ask you to comment on what you said about the high fructose corn syrup, which is very commonly used in the US. That, of course, is there's no doubt it is bad because it will promote the manufacturing of triglycerides in the liver. That's one of the major routes by which fructose is metabolized, and therefore it will raise the blood triglyceride levels. But then, sometimes these things are misinterpreted. Losing the sense of proportion, some people would say, well, fruits also have fructose, and therefore should we therefore avoid eating fruits? So maybe, you may like to comment on that.
Yes. I should have said that right away. Yes, this is something we really should understand. So it is very dose dependent. You need more than 100 grams of fructose. You will never get that by eating fruits. So it is all this artificial manufacturing where you really distill the corn and get all the fructose. So that is what is bad. It's almost impossible to get that much fructose and pure fructose. So when you eat a fruit, it's not just the fructose that you're getting. There is so much fiber, there are so many micronutrients, antioxidants. So nobody has ever been shown to actually have that from eating fruits. So it's liver, it's this fatty liver. So that's the main thing. So that these days it's not just heart disease. So it is the majority of people we see for a liver transplant. I work in a transplant clinic too here, is all related to a fatty liver. And I think that there's high fructose corn syrup. So when you drink, I don't know how many of you know these things. So the amount of the equivalent of this high fructose corn syrup in one 12-ounce can of regular soda in Coca-Cola. So my patients are like aghast when they learn this. We actually have like a little poster in our clinic showing this. So it is like about 13 teaspoons. So like 13 teaspoons of this fructose is what is there of sugar equivalent is there in one 12-ounce can. So can you ever imagine? So that's the thing so these very people, when they have coffee, so they would not put that 1 spoon of sugar because they think it is bad. And so they get this artificial sweetener. But when they drink their soda pop, so it is like 13 in just one 12-ounce. That's the smallest serving size. So that is where the high fructose corn syrup is bad. It's not that all fructose is bad. So, and especially when eaten as fruit, no. So that's, I think it's very important to make that distinction.
To highlight some of the important messages that you heard. One of them was about the years of preparation that is behind the disease. So what looks like a sudden heart attack is not as sudden as it looks. It is the culmination of damage that has been accumulating slowly over several decades, and quite often it shows up in the body weight. Sometimes, we try to look for the evidence of what has been going on in an annual blood test that has been done over, say, decades. But then that will measure various biochemical changes, the lipid profile in milligram quantities, and some of the chemicals also in nanogram quantities. Probably it will be much more practical to look at the body weight, which is sort of something which is staring at us without undergoing any test, in kilogram quantities. And be cautious before it reaches a level where this accumulated damage leads to a heart attack. Another thing which I thought I can take this opportunity to point out is that very often this heart attack is the result of an acute spasm of the coronary arteries. The coronary arteries suddenly become narrow. The partial block was already there as a result of the deposits, but then superimposed on that is an acute spasm, and the blood supply to a part of the heart is completely cut off, and that's what leads to the attack. Now, therefore, it's important to also know for the general public what are the factors which can precipitate this type of an acute spasm. And sometimes these things come together. Some of the main factors which can precipitate this type of a spasm are exposure to cold, drinking, smoking, getting emotionally excited, and a single heavy high-fat meal. We associate heart attacks or heart disease with a high-fat diet, but then we feel that once in a while it is okay, and it is taking fat regularly for a long period of time, for decades, that will increase the risk. That is true. But then what can also happen is that a single high-fat meal can be the cause of this spasm. And along with that, all the other factors that I mentioned. Now imagine a person who has gone to a party and it's winters. At the party, he has a heavy, high-fat meal, he smokes, he drinks, he has a heated argument with somebody, or at least an excited discussion, and then he walks out. Inside the hall was quite warm, but outside it's very cold, so he gets exposed to cold, and then he gets into the car. He reaches home. With luck, he's still alive, but then after he goes to bed, he doesn't get up the next morning. And people start wondering, What's happened to him? Only yesterday we saw him at the party. He seemed hale and hearty. Now what has happened is that he got this acute contraction of the coronary artery, the spasm superimposed on a chronic block which was already there in this type of a person, in which the preparation for decades had been going on, but so far he was free of any symptoms because that partial block still allowed enough blood to flow for him to meet the resting requirements of the heart and moderate, maybe a mild and moderate exertion also. He was not exerting much anyway. Another important thing that you brought out, which is again sort of more of academic interest, but still I found it very interesting, that some rare patients can be very educative. Like a person who cannot does not have the capacity to deposit fat in the adipose tissue, may be thin and lean, but then this person is at a high risk, and therefore this ability to be able to deposit the fat at the right place is something which is also a blessing. So the body is very wisely and wonderfully made. And along the same lines, another thing that you mentioned, a person because of a psychiatric disorder taking 25 eggs a day, again taught us that we don't have to be as afraid of eggs as people generally are. So these rare patients can teach us quite a lot. Sometimes, this again, I will digress a bit here. There are some patients who try various types of other alternatives for various reasons, not conventional or modern scientific medicine. They deviate from it. In addition to it or instead of it, they go and try something else. And sometimes they recover very well. And then they try to hide it from their doctors because they feel the doctor will be angry that instead of taking his treatment or in addition to his treatment, I went for something else. But I think we should encourage these patients to share what they did, because again they can teach us something. If something worked in this person, maybe it will work in somebody else also, and it might help us make up some of the lacunae that are there in modern scientific medicine, because modern scientific is about learning more and more. That is one of the beauties of modern scientific medicine, that it never says that it's reached the last word. Always more to learn. It's open to learning more and more, and we can learn also from these patients who do not follow the doctor's advice 100%. Then I think one of the most important messages was that even modest weight loss can be beneficial. So if a person is 50 kilos overweight, the person doesn't have to lose all the 50 kilos. Even if the person succeeds in losing 5 or 10 kilos, even that would help. And if he was a borderline diabetic or a borderline hypertensive, that might in fact push his blood pressure or the blood sugar levels within the normal range. And then again, instead of thinking too much about which diet is the best, we have to think in terms of adherence rather than the diet. There are many questions about dietary fat, and I might take this opportunity to also say that in the YES program we have going on these days the course YES.02, in which last week we talked in detail about carbohydrates. On Tuesday we'll talk in detail about proteins, and on Thursday about fats. The timings of these classes are 8:30 to 10 in the morning, Indian Standard Time, but then the timings may not suit you, but you can always watch the class recordings. The class recordings of the class on carbohydrate are already there, and those on the proteins and fats will be there soon after these classes have actually been held. Now it's a privilege to thank Vinay for this highly illuminating talk. Of course, I was not surprised. I always knew that he is an all-rounder, a scholar, and in fact has done in many ways far better than I did. And that's what makes a teacher truly happy. It's said that birds fly with their wings, but the teachers fly with their students. And it is students like Vinay who justify that statement. So thank you, Vinay, and I'm sure we'll have many more opportunities to invite you to speak in this YES program. And we look forward to having you again and again. Thank you again.
Thank you, Dr. Vishnani. Thank you.
Thank you, everyone, and thank you, Professor Vinaya. We just end with the meditation music, and thank you once again.